Hi, I'm Dr. Sarah Hurvitz from the University of California, Los Angeles, and I am a breast medical oncologist. It's been estimated that around 50% of patients diagnosed with HER2-positive metastatic breast cancer will develop brain metastases in the course of their disease at some point. And the question is, how do we ideally treat them? Up until recently, there have been very few clinical trials that have addressed this area of unmet need. There were some studies that have evaluated the use of lapatinib and capecitabine in this setting and have demonstrated objective response rates in the brain of around 20%. There have been other studies looking at lapatinib alone, which has shown an objective response rate of only about 5%. Studies looking at neratinib and capecitabine have shown around a 30% objective response rate, but certainly there has not been a home run systemic therapy that we can utilize to date. Our mantra has been that we generally use surgery and/or radiation therapy for patients who have CNS metastases and continue the systemic therapy that the patient is on if it's controlling the disease outside of the brain. If it's not controlling the disease outside the brain, then we switch the systemic therapy based on what the next line of therapy should be for the extracranial disease. In December of 2019, a study called HER2-CLIMB was reported, a phase 3 trial evaluating the HER2-targeted tyrosine kinase inhibitor, a pill, called tucatinib in combination with capecitabine and trastuzumab. In this study, they allowed patients who had active, untreated, or progressing brain metastases, and nearly 50% of patients in this trial had that. And they demonstrated that patients who received tucatinib with the capecitabine and trastuzumab had an objective response rate of nearly 50% in the brain. They had an improved progression-free survival as well as an improved overall survival compared to patients who received capecitabine trastuzumab. So it is now FDA approved and available for use. And my go-to regimen for a patient with CNS HER2-positive brain metastases would be to utilize tucatinib in this regimen. It should be noted that this regimen was not evaluated in patients who'd received prior neratinib or whose disease had progressed recently on lapatinib, or in patients who had received prior capecitabine. So the activity of this regimen in those patients is not yet entirely clear. Needless to say, this is an exciting time as studies are now ongoing evaluating this type of therapy in patients with CNS metastases, which does still remain an area of unmet need.